Hello, and welcome to our webcast for September 14, 2018. My name is Christian Debré, and this is Amy Asbrook, the director of Toujours Vivant, Not Dead Yet.
Hello.
And down here, somewhere here, okay, is Taylor Hyatt also joining us as our policy analysis and outreach coordinator.
Hi.
Toujours Vivant, Not Dead Yet is a non-religious organization by and for people with disabilities and our allies. Our goal is to inform, unify, and give voice to the disability rights opposition to assisted suicide, euthanasia, and other ending of life practices that discriminate against people with disabilities. Today's topics, we have two this week. So, review of Health Canada's final assisted suicide and euthanasia monitoring regulation.
Yeah.
The second one is a new suicide prevention initiative in Switzerland. Bizarrely, it is the country where everybody could suicide himself the way he wants.
Assisted suicide law, yeah. Okay. So, review of Health Canada's final assisted suicide and euthanasia monitoring regulations. So, as you may recall, you may or may not recall, in December of 2017, Health Canada released its draft version of the regulations for monitoring and reporting on assisted suicide and euthanasia across Canada. And that was 18 months after the procedure was legalized.
Really funny. You receive a game, any kind, and 18 months after you receive the rules to how to play.
Right, exactly. So yes, and it took with another 6 months. It was more than 2 years when the final regulations came out that people were being euthanized without any monitoring rules. Okay. So they requested input from the public, which is their obligation under, in federal law. When they propose regulations, they have to get public input. So Toujours Vivant, Not Dead Yet, submitted detailed comments, which you can read on our website. And there's a link in our text. So at the beginning of August, the final version published. Health Canada reported that there were 43 submissions received in total, only 3 of which were provided by advocacy groups.
So it's mean that they doesn't have so much thing to read. They have 3 to read who are against, and
it's not against. It's like
comments,
kinds of comments
from people who are normally against, and few of positive one. Okay, they doesn't have even to read the whole 4 or their 40. Okay,
right.
So it's not an enormous job. They just have to read.
Right. The interests of the 3 advocacy groups who submitted comments were there. Apparently, from what Taylor told me, she did some research on this. One was a single nurse, one was a religious organization, one was Toujours Vivant, Not Dead Yet.
Sorry. I guess I misspoke when I was telling you about this.
Oh, I'm sorry.
The way that wasn't who the advocacy groups were. It was the way they listed them.
Oh,
they had a certain number of healthcare professionals or healthcare organizations, and then they listed 3 advocacy groups, one of which was us, United Church, and an individual nurse.
Okay. So basically, we have 3 organizations that are interested in issues other than doctors and institutional issues regarding the regulations, and then everybody else.
So it doesn't change the thing that they doesn't have an impossible task to read those things.
Right.
It was relatively low number of proposition and suggestions from
Right.
people.
Right. And like I said, only 3 submissions were provided by advocacy groups. Unfortunately, Health Canada didn't act on most of our suggestions, and the final regulations contain many of the same problems as the first draft. Some pretty detailed comments. Taylor, what did you want to add?
Yeah. I'm just still mad that they lumped us in with 3 other groups and the United Church and a couple individuals. It makes us look like we're on some sort of fringe. Do you think they were expecting a mostly religious opposition, a sanctity of life opposition, or someone else who wasn't making clear human rights oriented arguments?
Yeah.
So it's mean that they doesn't have read our document.
Well, probably they read it, but given the number, most of the comments probably came from institutions and doctors groups and nurses groups. So they had the point of view of doctors, nurses, and administrators. And then there was us.
Yeah.
So there probably weren't many who shared our point of view. And so it didn't look like, they probably didn't think many people shared our point of view, basically.
Right.
But in fact, I think we were speaking on behalf of people who are potentially endangered by euthanasia and assisted suicide, and our points were very important.
And who, within the medical system generally, we can be brushed off or underestimated or mistreated.
Yes, yes. Okay. In the background section of the new regulations, Health Canada rejects any duty to ensure compliance with the law's safeguards.
Oops.
Yeah. So the Supreme Court in Carter said you have to do these strict safeguards to protect people who are vulnerable. But here is Health Canada saying, no, we don't have any obligation here.
Oops. That's very weird.
Yeah. The regulation states, monitoring is fundamentally distinct from a process that seeks to assess individual medical or nurse practitioners' compliance with the criminal code exceptions. Investigating instances of non-compliance with the eligibility criteria and procedural safeguards set out in the criminal code falls outside the scope of the federal monitoring program and is under the purview of local law enforcement.
Something I doesn't understand. Criminal code is a federal responsibility. It's very clear. Nobody do any special thing about the Constitution, whatever. It's clear this is federal. And federal say it's not our job.
Right, but I mean, I can see a legal justification that they could use, which is laws are enforced by the local law enforcement. But I think that that's a little...
Yes, I agree, but the rules are federal. Okay, right. It could be the Quebec police to apply it.
I think it misses the point, is what we're saying, that, they were given permission to make an exception to this law prohibiting assisted suicide. And in doing so, they were supposed to create a very strict system with close monitoring. And now they're saying, no, it's not our responsibility to monitor if things go wrong. And that just really burns me.
And on top of that, if the law enforcement is local and the policing is at the provincial and municipal levels, how are they going to have the medical expertise and the expertise on this issue to know when something has gone wrong? It seems way outside of their wheelhouse.
Well, at the Quebec police, have the responsibility to do any inquiry about those crimes.
Right. And we've already seen this happen because in the reports that the Quebec Commission on End-of-Life Care has produced, there have been several incidents where the euthanasia was of a person who was not eligible.
So,
but the police have done nothing about that.
Even it is somewhere related to a crime. Okay, maybe it's not. Maybe it's just some kind of bizarre thing, but it should have an inquiry.
Right.
It's a minimum.
Right. And people say, you know, they say, well, you people panic over everything, nothing to worry about. This is what we worry about. Right here, when the government, yes, we understand that technically police are supposed to enforce the laws, but when they just gave up responsibility for enforcing the safeguards, that is not a good thing. Okay. So again, if the purpose of monitoring at the federal level is not to ensure compliance with the law, what exactly are they monitoring?
Nothing. They don't monitor anything.
Right.
They count the dead. That's all they do.
Right. Right. Exactly. The regulations won't collect enough information to know whether the person who wants to die is subject to external pressure, either from another person or from life circumstances. So they won't have enough information to make that judgment. And that is supposed to be an eligibility criterion, but the doctors won't have enough information to answer that question. There is no plan or procedure to fill in incomplete information or track down missing reports. And we feel that every death needs to be completely and accurately documented. And again, just a sec. Again, getting back to the Quebec End-of-Life Commission reports, a large percentage of the reports submitted by doctors were incomplete, and they had to go back and forth several times to complete those. And some of the doctors even refused to give information. So not having a procedure for doing that is the problem. I'm sorry, go ahead, Taylor.
Sorry, all I was going to say, it's more than what we feel. It's what we know and what we've seen go wrong in other places.
Right, exactly.
Yeah, and we are not different as other places.
Yeah.
We are very like in Oregon or other place where they have assisted suicide and euthanasia.
Right, and in the lower court, in the Carter case, the judge said there aren't any problems elsewhere, and this is the reason there aren't any problems, because there's no follow-up when the reports are incomplete. And there's no way to know when doctors don't submit their reports. There's no procedure, and that is going to be this case in Canada as well, and it's going to be the same problem, and it's going to look fine, but it's not going to be.
And it is kind of impossible that there is no problem at all. It doesn't exist. Humans are imperfect, so they have to do some mistakes.
Right, and you know, the judge in the Carter case said, yeah, well, we understand there's some risk, but we're going to have this nice, secure program with lots of safeguards, and everything's going to be fine.
That nobody look around.
Right, so here we are, right up against it with the safeguards, and what we're finding is
nothing exists.
Not useful. Okay, a few words and phrases that are carried over from the earlier draft allow for ambiguity or the abandonment of responsibility throughout the assisted suicide process. And these phrases are repeated. One of them is 22 times, the other is 11 times in the regulations. So it's not just this happens once or twice. Information must be provided, quote, if known.
If known.
Yeah. Okay. So this means that medical practitioners don't have to find out whether certain eligibility requirements are met or safeguards have been followed. So, you know, how's that a safeguard? Basically.
Yeah.
Again, practitioners must report, quote, to the best of their knowledge or belief.
Wow.
Wow.
What a criteria.
Yeah, right. Again, this relieves them of the responsibility of finding out, seeking out, and verifying the information. It loosens eligibility requirements and makes data collection more difficult. There aren't many ways to verify what the practitioner knows for sure. So again, you know, they're just like letting the information go.
Not our business. Just don't look. If you don't look, there is no problem. Don't look.
Don't look behind the curtain.
Yeah.
Regulations don't document the role assisted suicide advocates play in the application, referral, and eligibility determination processes. Oops. So these are groups like Dying with Dignity, who are setting up whole service infrastructures where they help people find that second doctor who's going to agree with your first doctor that you are eligible for assisted suicide.
Yeah, and when you mean help, they say they push.
Yeah.
Most of the time.
Yeah, exactly. They have their one track that they're going to send you along, and that is to euthanasia. But there's no, they're not going to even try to record how much these people are having influence in this process.
Anyway, it's a public knowing that that doctor already exists.
Right.
I could give you a name. In Quebec City, it is Dr. No. Everybody knows that.
NAUD, not NO.
Yeah. Not the same. But somehow James Baum is not the same. Exactly.
Yeah.
Not the same kind of killing. Not
Not
the
right.
one. There was one using a gun and the other one used some
Syringe. Yeah.
Oh.
Okay.
But they do the same job. They kill
Yeah.
people.
Yeah.
Right.
The demographic information collected from the person making the request is limited to date of birth, sex, health insurance number, and postal code. It does not include data about the person's race, ethnic background, first language, disability status, or other possible basis of discrimination, knowing that Indigenous people are systematically discriminated against.
We know that. It's a public knowing that they are discriminated, and there are some inquiry, and there's many inquiry of those kind of things, and ask to any Indigenous people, they will tell you, okay?
Right.
And it doesn't collect it, so we never know if they are more subject or less subject.
Right.
And there's many other groups who are discriminated.
Right. They don't care to know this information.
Yeah, don't look. If you don't look, you will never find any problem.
Right, no problem here. They don't collect information about income, assets, and source of revenue to determine whether the person is subject to economic pressures. They don't ask about the person's living situation, their household composition.
And we know.
And the kind of residence. So whether the person is in residential care, a private home, a hospital, whether the person's homeless, or whether they're in prison.
And we are already knowing that in a lot of care.
In long-term care homes.
Residence care facility doesn't give a good quality of care.
Right.
Some, okay. You are disciplined, you are pressure, and if you receive pressure, it is a murder.
Right. They're not collecting information about the onset of the person's quote, grievous and irremediable medical condition, unquote, whether or the needed services and support and costs that aren't covered by insurance. So again, they're not gathering information about factors that could affect the person's decision. And finally, the biggest one, they're not collecting indications of abuse or inhumane living conditions. So
every week in newspaper, you saw very bad story about history.
Right, and in Quebec, there's currently a class action against the province for inhumane conditions in long-term care facilities because the conditions are so bad and the staffing is so low.
I will never like to go to certain care facilities because their food are so bad.
Yeah.
And I like food.
Right. He's a person. He loves food.
Another thing that I left out was the kind of info that Health Canada does want to collect. If you're homeless or you're financially badly off, you might not have access to the documents that'll give them the demographic info they want.
Right. They ask a question that could sort of possibly answer the question whether the person has a primary care doc, but they don't. They should just ask, does the person have a primary care physician? But they don't. So that's silly. All right, the regulations reflect the idea that being eligible for assisted suicide and euthanasia, that is, having intolerable suffering, irreversible decline, and foreseeable death, is itself the reason to ask for it. And that's really,
which is not.
That's really the thing that they're basing it on. They say, we don't need to ask about any other problem because if you're eligible, it's reason enough to have assisted suicide. But to understand what factors prompt some eligible people to ask for death while others don't, the monitoring program should dig deeper. It should gather data about loss of autonomy, about loss of ability to do favorite activities, loss of control over bodily functions. And these are all things that are gathered in Oregon and Washington.
Yeah.
About feeling tired of life. That's something that's being introduced in the Netherlands as a justification for euthanasia. About a perceived loss of dignity or feeling like a burden, about economic hardship, psychological, spiritual, or existential distress, unrelieved pain, unrelieved physical distress. So that could be, you have a lot of vomiting with your chemotherapy or something like that, or fear of pain or physical distress. So they should ask about the reason the person has asked for assisted suicide. But
and you will be surprised sometimes the reason is really easy to.
They do ask about the medical reasons, but they don't, and that's in terms of establishing the person's eligibility, but they don't ask about why, the person, him or herself, why they want assisted suicide or euthanasia. Okay, one positive feature of the final regulations.
Oh, there is positive thing.
Yay!
Yeah,
is that they include questions about whether the person has access to palliative care or disability supports. So that's a good thing.
That's a good thing.
That's a good addition. If the person's request does not end with the death by assisted suicide or euthanasia, information about the application, the eligibility assessment, and compliance with safeguards may be disposed of in 90 days. In this way, Health Canada will lose valuable information about people who withdraw requests, who die before they are euthanized, or who are deemed ineligible. So it's like, oh, we don't want to, it's okay if we don't have information about them.
Just sweep it under the carpet.
Right. Right. Yeah. Especially people who withdraw your request, it would be nice to know why. Like maybe they got services they needed.
Maybe.
The regulations provide minimal monitoring of the deaths themselves. So Health Canada makes no effort to gather data about who administers the drug in the case of assisted suicide. So the person gets the prescription, they take it home. Does the person take the drug themselves? Is it their sister who chops up the pills and puts it in pudding and gives it to the person? Does the person actually take the drugs at all? You know, they don't track this information. They have some yes or no questions, but they're incomplete. They don't capture all contingencies. And they don't track problems that arise during the process or actions that are taken to solve those problems, the time to death, or the effectiveness of the drug cocktail. So we know of 2 studies that were done before the year 2000 about drugs used in assisted suicide and euthanasia. That's 2 studies. That's not enough. There are small samples. We don't know enough about people's reactions to the drug, what drugs are effective, blah, blah, blah.
And there is something that we are knowing for sure, that even in the death sentence, there is some problem. Specialized people to kill people miss their way to kill people. There is people who take 2 hours to die. There's people suffering a lot before dying.
Right.
So if professional in the dying of people missed their way to do it, it may have problem in the field somewhere.
Right.
Why? Not knowing.
Exactly. There is still no procedure in place to deal with a disagreement between the 2 medical practitioners who must approve the assisted suicide and euthanasia request. If the second doctor believes the person is not eligible, that should immediately derail the approval process. The request should be denied, and the person should only reapply if and when they meet all the eligibility criteria. But if the first doctor can keep searching for a second practitioner who agrees with the euthanasia.
1, 2, 3, 4, 5, or 10.
Right, doctor. What is the use of having a second opinion as a safeguard?
Just get rid of the second doctor. No need.
Right. I mean,
didn't Quebec do something very similar to that?
No, not quite.
Not exactly.
Quebec said that the second doctor doesn't have to be independent of the first.
Okay.
So it's close, but no cigar. In the Carter decision, the Supreme Court asked the government to create a carefully designed system to regulate assisted suicide and euthanasia, imposing strict limits that are scrupulously monitored and enforced to protect vulnerable persons from being induced to commit suicide in a time of weakness.
I think that those rules are far to be strict.
Right.
Far away to be strict.
Okay, but as the activist Catherine Frazee said in her recent editorial, which we link to, the regulations fall short of even a good faith effort to understand the role that social determinants of health, such as poverty, insecure housing, isolation, or social stigma, may play in motivating a request to die. And Ms. Frazee suggests that to monitor medical assistance in dying responsibly, we must hear more voices, consider more perspectives, probe for more answers, and be more fearless in the face of what those answers might reveal. Because, you know, if we have a program that's only going to show everything's happy and groovy, then, you know, but that's not the truth. So, Taylor, did you want to add a comment on that?
Oh, I was just struck by Ms. Frazee's mention of fear. What might investigators be afraid of? Finding out that this practice, which is supposed to give you freedom and promote equality, actually does the opposite. Finding out that people have wrongly lost their lives over 2 years and we've made an awful mistake.
That's all the fear. Okay. A new suicide initiative suicide prevention initiative in Switzerland. Earlier this week, we found a story from Switzerland, a new...
Not a story.
About Switzerland.
About Switzerland, not exactly.
About the Swiss, right. A new tool designed by the Swiss government is supposed to connect all of the country's suicide prevention resources on one website. So that's a good thing.
Yeah.
You know? That one-stop shopping, that's a good thing.
That's always a good thing.
The site's release is part of a nationwide suicide prevention plan. It was launched to coincide with World Suicide Prevention Day on September 10th, which happened this week. Their goal is to reduce the number of non-assisted suicides in Switzerland by 25% by the year 2030.
From non-assisted suicide.
Right.
Oops.
In other words, to prevent about 300 suicides per year. Prevent 300 suicides. So 300 is 25% of a little over 1,000. So, 1,200. So that's how many suicides they have, 1,200.
Yeah.
As usual, we are frustrated by the commitment made by many governments to reduce traditional suicide deaths, while assisted suicide is ignored and even applauded in Switzerland. In fact, there are almost as many assisted suicides as traditional suicides. 965 Swiss died by assisted suicide in 2015. So 1,200 regular suicides, 965 assisted suicides. It's coming up.
And for us, a suicide is a suicide.
Right. Preventing one kind of suicide while condoning the other makes no sense unless you devalue, you discriminate, you devalue, So there you go.
Okay. Is your life worth less or more at the last time of your life, or a bit before?
Right.
Think about it. Well, my last minute worth as much as any other minute of my life.
Right. Okay. Taylor, did you want to add anything else?
Not that I can think of.
Okay. All right. For more information about the subjects that we discuss here, and there's a lot, you can visit our Facebook page at facebook.com/toujours vivant, not dead yet, all one word. Visit our website at tvndy.ca. You can email us at info@tv-ndy.ca, or you can follow us on Twitter @TVNDY. Thanks to Christian for helping out.
Thank you,
and
Amy.
to Taylor also. And we will see you next time. Bye.
Bye.